This next series of videos is going to discuss chronic kidney disease, or CKD, in the primary care setting. We're going to talk about why it's so important, how to diagnose it, how to screen for it, and most importantly, how to manage it in the primary care setting. It's based in the 2024 KDIGO guidelines, which just came out and inspired me to make this series in the first place, but we're also going to be talking about other guidelines such as some European guidelines, as well as additional guidelines from KDIGO: blood pressure, diabetes, mineral and bone disorder, and of course, hyperkalemia. It's so important to talk about CKD because we have a lot of tools at our disposal as we're managing it to prevent kidney replacement therapy or dialysis, as well as the adverse cardiovascular events we frequently see with CKD. We'll spend a lot of time for how and when we would screen for CKD. Briefly, hypertension, diabetes, ASCVD, and a history of AKI are great reasons to screen for CKD. And it's really important to get not just the eGFR, but also the level of albuminuria, because it's easy to forget about that, and we need both of those to diagnose and stage CKD. We'll spend some time talking about the variability in eGFR, how it's important in clinical practice, as well as the use of cystatin C when we need to get through that gray area. Monitoring CKD can be really tricky, so we'll spend some time diving through some cases about different patients at different stages of kidney disease and how often we would be checking their labs and what would we be measuring in the first place. 2024 is a great time to be talking about CKD because when we're talking about how we're monitoring it and the additional cardiovascular risk, we have new calculators instead of the traditional ACC-AHA 10-year risk calculator so that we can take the patient's CKD into account when determining their overall risk. There's so many moving pieces when it comes to a patient with CKD, such as their blood pressure, their blood sugar control, hyperkalemia, and all the lifestyle interventions that we're counseling on. In addition to ACEs and ARBs and hyperkalemia, we can't talk about CKD without talking about the SGLT2 inhibitors. In addition, we'll spend some time on the GLP-1s, the newer agents like the nonsteroidal mineralocorticoid receptor blockers, such as finerenone, and more. We'll also talk briefly about mineral and bone disease, metabolic acidosis, and anemia. These are more commonly managed by nephrology, but we see these in primary care, so it's important to understand how they're treated. Finally, we'll spend some time diving into cases of patients that we might be referring to nephrology, most importantly with the kidney failure risk equation, which is really emphasized in the new KDIGO guidelines. The kidney failure risk equation helps stage the overall risk for patients that we're managing in primary care, and we'll catch patients that might have slipped through because of the classical teaching where you wait until the eGFR is 30 to refer to nephrology. Many patients, especially if they've got increased albuminuria or other changes or other guidelines that we'll talk about, might benefit from a nephrology referral sooner. So it's really important to understand the when and the why. After you complete this video series, I really hope that you understand why it's so important to be cognizant of CKD in primary care. It's a huge predictor of future morbidity for our patients, and we have a lot of tools that we can do as primary care providers to help reduce our patients' risk. So stay tuned as we dive into tools for screening for CKD, management with agents like RAS inhibition, SGLT2 inhibitors, GLP-1s, and finerenone, and how you can prevent your patient from having their chronic kidney disease progress.